Hi everyone, and welcome to the inaugural podcast for the Radiation Oncology Education Workgroup. I'm Pearly Khaw. I'm a radiation oncologist from Melbourne, Australia, and the current chair of the Workgroup. For this first podcast, I have the privilege of interviewing our recent recipient of the Lifetime Achievement Award, Professor Carien Creutzberg from the Netherlands. Welcome.
Thank you so much.
What we thought we'd talk about a bit today is just a little bit of how did you get started in this arena of research?
Well, I didn't really get started in an arena. I was just still a registrar in radiation oncology, and the question, if all those patients who we gave post-operative radiation for early stage endometrial cancer really needed the treatment because they were prognostically so favorable and they lived with symptoms. So there was a current question at that time, do they all need it? And it was felt that we should do that in a randomized trial to see if we could find out who would or who wouldn't benefit from the radiation therapy. So that's how my supervisor at that time and me set out to write a protocol, submit for a grant, and start this trial. And because the question was so sort of valid in whole of the Netherlands, there was really an enormous support for this trial, which made it really easy to get it off the ground.
Was it hard to actually design the trial question?
Well, the question was not that difficult. There was some discussion about eligibility criteria. For some of our colleagues didn't really dare to leave out the radiation therapy. So we negotiated the entry criteria a bit. And at that time, there was less administrative burden along with clinical trials. It was still, of course, there was the ESSA committee. Of course, you had to have a grant and support, but then you could start the trial. And because the question for patients was difficult, so either they would randomize to 5 weeks of radiation therapy or to no further treatment, that was the challenge to really explain this to patients. And we were so lucky that with the whole of the Netherlands participating, we could enter these 700 patients in the trial.
Was it also difficult to actually write the grant application that gave you the funding to start the trial?
I don't think it was that difficult. Of course, you had to have a scientific background, right? But as I said, the question was felt throughout the community, not only the radiation oncologists, but also very much the gynae oncologists. So all who were in the area of evaluating the grant application, I think they found this a really important caveat and knowledge.
So we know the Netherlands are excellent at recruiting patients to trials. You've got a long history of this, not just in gynae oncology, but across many different tumour streams. But for many of us outside of the Netherlands, what advice would you give us if we were going to try and start walking this pathway as a junior resident, junior registrar, junior consultant, having never walked this pathway before? How easy was it for you to get started?
Well, the first start, of course, was supported by my supervisor. So they had been in the field for a long time. So at every MDT, at every meeting we had in gynae oncology in the Netherlands, these discussions would be there. So when you get a feel that when you have a patient sitting across you and you don't really know what's best for them, then you have potential trial, because we all want to do the best for our patients. So if there is a really caveat and knowledge, but everybody would like to answer, that's where you have to go to see if together you can solve this question. And what I found in all of the years, that people love working together for something that's felt to be important. So in the Netherlands, of course, we are a small country. We have short lines of contact. We've been raised in a context of many trials, as you say, for many different tumor types, and that helps as well. The infrastructure for good clinical trial biostatisticians, the infrastructure for pathology is all well taken care of. Yeah.
So in some ways that sets you up to succeed.
That's right, yeah.
I'm jealous just pointing that out to everybody else.
But in that time, we're now talking like the 1990s. Huh?
Yep.
So I think we were all proud to complete this trial, and the whole group of the people in the Portec group, we were together proud of this trial. And then when we wrote it up, and it was published in Lancet, and it really had impact on the treatment decisions,
yep.
then everybody looked to each other and said, what are we going to do next?
Yeah.
And then at that time, vaginal brachytherapy was emergent as a maybe better and non-toxic alternative, because we had found in Portec 1 that most recurrences, if they were found in the vaginal vault area. So that was the sort of natural new questions for the next trial, and that's how we set up Portec 2. And then young Remy Naut was in my department, and he was really enthusiastic about this. And so that's how, with the pathologists who said, well, this is an excellent opportunity to have a biobank. So we already had blocks coming in from Portec 1. At that time, you didn't have to have a separate consent for that, so that was easy. And then we started with Portec 2 to have it as a prospective biobanking.
So even in the Portec 1, you started recruiting in the 1990s. So even at that time, you were already thinking about translational research before it's become even,
Yeah, in Rotterdam, in the Portec 1 at that time, we had pathologists who were really thinking forward already. And there was already a group of pathologists in the Netherlands, gynae pathologists, working together. So they were already doing research together with tumor blocks, and they had already a sort of code of conduct when you could use tumor tissues to answer valid questions. So yes, that was already a sort of thing you naturally were thinking of. Yeah.
So with Portec 2, and I guess for want of a better word, our discovery of Remy at that time, did he find you or did you find him?
It was a natural thing because I was one of the supervisors in the radiation oncology training. He was then a registrar. So he was very motivated research-wise, curious, and he was interested in gynae cancer. So it was a natural sort of development that this was a good project for him to analyze, publish Portec 2. We were discussing with our gynae pathologist, Professor Vincent Smith and Dr. Charling Bosse, and Charling and he got to be the young team, the upcoming people, and they were really doing such a good job.
Do you think that's kind of inspired our next generation? Because Portec 3, we've seen Stephanie de Boer emerge, and as well as Kathleen Post, and now Bastian with Portec 4. It seems almost like you've had this generation follow.
Well, yes, in a way. I think if people see enthusiastic people who are trying to answer new questions, and what comes out of that it is inspirational and also motivating to, in your training, to learn to combine your clinical work with research questions you are encountering just on your way when you're recommending treatments to patients. And we've now Anne-Sophie van der Herik on Portec 4A, obviously, and with the new team on Rainbow trials. So yes, the group was growing, and after that Portec 1 and 2 were published, the international community picked that up, and that's how the GCRG was really interested in also doing a collaborative trial in high-risk cancers, because they are less frequent. So we really needed the international collaboration to be doing a good trial for high-risk endometrial cancers.
So Portec 3 was really like your first opportunity to reach out to the international community. How did you find that? Was it difficult? Was it easy?
I was made very welcome in the GCRG, and people who were then doing really important trials like Gillian Thomas, Henry Kitchener, they were really role models for me to see how they discussed with humor, with fun, with friendship, and together looking for the best research question to pose at that time. And they were also really welcoming, saying we can better do one trial together than all do competitive trials and not finishing them because there are not enough patients of a certain category. So they decided that they would participate in PORTEX-3, and that's what made PORTEX-3 an international success. And quite early on, when we had the GCRG meeting also in Leiden around all the current trial questions at that time, it was clear that a joint biobank would be so important because of the rarity of higher risk and more advanced stage disease. And that's how with Henry Kitchener, with Gillian Thomas, and with the pathologists internationally, we had the first then to be transported consortium meeting.
Yeah. Because they kind of started developing together. Because I remember my first meeting with you was in Noosa in Queensland when you came out to an ANZCOG meeting to speak to us about PORTEX-3 then.
Yeah, Michael Quinn was very much a part of the GCRG, obviously. So yes.
At that point, but for us, I know in Australia, the whole concept of biobanking was still very, very new to us. So how difficult was it for you to kind of bring all of that together to get everyone on board? Because from personal experience, I know getting those blocks to you did prove to be challenging, shall I say?
Challenging, but also rewarding, because with the then emerging molecular factors, we're in a position to really find out some of the prognostic and predictive properties. But yes, you need in every group a champion who is in his own group and in his own country, someone of authority. And of course, that was Michael Quinn at that time in the ANZCOG group. So inviting me to Noosa, which was a wonderful place, by the way, together with the young Rob Coleman at that time, yes. But it was fantastic. So we could explain and talk about, and I remember that this was new in Australia because half of the pathology labs did not want to release blocks, other half did, they did understand, and we were saying, well, if a patient sends a consent form that she wants her block to be used for new knowledge, in fact, she has a right to demand that from the pathologist. So we had that discussion as well, who's going to decide on the blocks. So that was very much a sort of, I think, a transition of thinking for are the blocks in the sort of pathology labs ownership, or are they in fact owned and governed by the patient herself?
And with this, we've now got the fantastic biobank that is leading, I guess, the TransPORTEC questions. And through that, we can see that there's a huge amount of international collaboration with now the Rainbow trials. Do you think that that naturally evolved, or was it simply that suddenly people felt that this was an opportunity to come together and be able to ask these questions?
Yeah, I think it was sort of a naturally evolving of we want to know more, because from the first PORTEX trial to the third, you found that you had a result. Well, in PORTEX-3 we had initially a 5% survival difference, which was just significant, but we saw that some subgroups had a much bigger survival benefit and others seemed to have none such a survival benefit. So then you go looking for signals, who is that? And without the translational research, you can't really find it out. So we were then transitioning from the standard clinical pathological factors to the molecular factors, but also to factors such as the quantification of lymphovascular space invasion. So there were more players in the field which were emergent, and we tried to find as much evidence about that as we could. And it was very much a sort of thing felt both equally important by the pathologists in our translational team. Internationally, we had also David Church in the UK who was doing much work on POL-E tumors. We had, of course, Navina Singh, who is so sadly deceased recently, but she did a lot of work also on the gynae pathology. So the group of the gynae pathologists working together in this was really amazing.
And do you think, though, as we move forward, are we actually going to find enough answers, or do you think we're going to actually find more questions?
I think we will always be finding more questions. So you answer the current question, and the next is already sort of nagging in your back of your head. Okay, but now this question. So yes, you have always to be staying curious and to stay on the verge of where are we going. And now we get, of course, the data on the immunotherapy. That's also one of the rainbow questions. But is that, again, a cure for all, or should we really be very critical in whom to give it and whom should have something else? What is the role of radiation with or without the immuno? Do we need chemo with immuno? Maybe we don't need the chemo. We only need immuno, maybe some radiation. So there are lots and lots of really valid questions. And the name on our team, which we haven't mentioned yet, Nanda Horeweg, she's of course a amazing researcher as well, and she's very much in the center of coordinating the rainbow trials internationally. So yes, the story will continue.
So for any younger researcher out there, don't feel despondent that the questions seem to already have been asked.
Oh, no.
Keep asking questions.
Yes. And have a critical view always on your own sort of protocols. Why are we doing this? What am I reading and hearing in the congresses and the literature? So what is our next question? Yeah.
And I guess critically, being both radiation oncologists here, how do we look to encourage our younger colleagues to move into this space and perhaps not get too caught up in our high-tech side of radiation oncology and be willing to keep asking these questions and see a role for us to play in this space?
I think radiation oncologists are very much an important core member of the multidisciplinary team. And I think only few of us are really more on the technical side, playing with new techniques. I think many are really on the clinical multidisciplinary treatment. And I think we are really needed in the core team with our gynecological oncologists, with the medical oncologists, but they are newer. They used to treat only the patients with metastatic disease. Now, of course, some of the immunotherapies are moving to the advanced stage primary disease, but together, if we discuss really well in our multidisciplinary team, together we can have the most cutting edge question.
So I guess the final statement would have to be that, yes, we remain a multidisciplinary group and we need to keep focusing on our multidisciplinary group as we find the next set of questions.
Exactly. And be confident as radiation oncologists that we have a lot to bring in the multidisciplinary team. Yeah.
So thank you very much for your time today. It's been very inspirational, as always. And congratulations again on the Lifetime Achievement Award.
Thank you so much, Pearly.